All right, can we go? Can we start? You want to behave so we can actually do this, Anton?
No, I should be like misbehaving.
We are not shaming people who get COVID, Anton.
Definitely not. We're just shaming Marco.
Are we ready?
Is This Going to Kill Me? A health podcast with Howard Feldman and Dr. Anton Meyberg.
Full disclosure, in fact, there are two full disclosures. Number one, I hate sleeping. And number two, tired people irritate me. I'm Howard Feldman, and this is an episode of Is This Going to Kill Me? It is Sunday, the 26th of March. And of course, joining us in studio, as always, is pulmonologist and physician Dr. Anton Meyberg. How
Morning,
are you?
Howard. Full disclosure, I love sleeping.
Yes. And I'll bet you tired people irritate you.
I think tired people irritate everybody.
They do.
You know,
What is wrong with them? Can't we just
cranky and moody and
Can't we just sleep when we're dead? Isn't that just simple? Sleep.
Look, it
live,
just says a
live
lot
when
about you.
you're alive. Sleep when you're dead. That's it. Podcast over. Let's go and enjoy our Sunday.
I think what you're trying to say is that basically adults from the age of 18 to 60 need about 7 hours sleep a night in order to function, and over 65 need at least 7 to 8 hours. So you need at least 7 to 8 hours sleep a night, okay, to function. And that's
never
why
slept that in my life.
Maybe in a week you sleep that. That's why you're so cranky and moody, and it makes sense. Okay.
Me. Okay, so can we, seriously.
Yeah, that's serious. That is serious. Adults need 7 hours sleep a night, and over 65, 7 to 8 hours.
Who says?
It's according to the sleep studies done worldwide, and this is
All right, let's roll this back.
Every sort of study we know about.
Let's roll this back. Okay, because let's start from the beginning.
Adam and Eve.
Not that far back, but let's talk about sleep. Do we seriously need that amount of sleep to function, and what does sleep do for us?
So adults typically are awake for about 2/3 of the day, which is 16 hours of the day. Okay. If you think about it logically, I'm not taking you, but I'm saying most people wake up generally around 6 o'clock and go to bed around 10 o'clock. That's the general population.
Okay.
And they get about 8 hours sleep. That's what a person needs. Now, why do you need the sleep? Because the function of sleep is to restore your body's function and to clear your brain. When I say clear your brain, it clears out some of the toxins and clears out some of the hormones in the brain that allows your brain to restore itself and almost reset. And we get different types of sleep. So we get what's known as sleep staging. You get REM sleep and non-REM sleep, which is rapid eye movement sleep and non-rapid eye movement sleep. And these are the different stages of sleep that develop when you go to sleep. And we know that the dream phase happens in the REM phase, which is the rapid eye movement phase.
So that's not the deep sleep.
That's your deep sleep. I'm
saying REM is deep sleep.
Yeah, deep sleep is when you dream and then you get interrupted. And through this whole process, you develop all types of problems with your functioning if you don't sleep properly. So I think the problems we're going to talk about are things like sleep apnea.
No, but that's a cause, not a result.
Well, is it? Because you're not sleeping properly, therefore your sleep is fragmented.
Okay, so let's look at that. What happens before we get to sleep apnea? What happens if a person doesn't get enough sleep, hormonally, brain-wise, all of that? What happens if they don't get enough sleep?
So once again, you get a release of hormones when you sleep. For instance, things like melatonin and your dopamine and all your other
I thought those
hormones.
were things that came in little tablets, no?
Yes, for certain people that are tablet junkies, you can get anything in tablet form.
Fine.
But you need to rebalance your body by sleeping. And the sleeping is, in effect, something that takes a busy schedule and unbusies it. So when you go to bed at night and when you fall asleep, and the worst thing to do before you go to bed is to look on your cell phone because of the blue light, which completely will interrupt your sleep and takes away from you falling asleep. When you go to bed at night and you fall asleep, you go into, as I said, a restorative phase where your body replenishes itself. It's almost like rebooting.
And that helps you on every level.
That helps you on a cellular level, on an atomic level, on a physiological level, hormonal level, because we know when people don't sleep properly, there's consequences, and those consequences could be obesity, those consequences could be worsening of blood pressure issues, cardiovascular issues. In fact, people present with daytime sleepiness, and they get fragmented sleep from not sleeping properly, so they sleep an hour here, an hour there, interrupted sleep. It adds to irritability, to mood changes, and as I say, you eat more, you eat badly, you get cranky,
That
you
there's
get
no
ratty.
doubt about. I know, because if you have run on a little bit of sleep, you'll end up eating high energy foods because you feel you need to keep
Replenish,
going.
replenish your body. You need to refuel.
And you're looking for fuel in a different way. I actually spoke on my show the other day. I actually interviewed a psychologist on sleep, and she was talking about the fact that for some reason your sleep before midnight is, or till about 2:00 in the morning, if I'm not mistaken, is more valuable than sleep later on.
I mean, I find that if I get woken up at 1:30 in the morning per se,
Yeah.
I can have slept so deeply until that point, you feel like it's almost enough, knowing that
So
it's
you'd
not enough.
agree
But
with
it's a
that? I mean,
deep
obviously
sleep.
it's
You go
not-
into
not on
deep
a
sleep,
regular
and it's
basis,
a physiological, but you go into a physiological sleep where your body completely shuts down. And yes, you cannot survive on 3 hours sleep a night, but you can survive once in a while on a little bit of sleep.
Can you catch up your sleep?
Never. You can never catch up to you. So the fallacy of that,
Yeah,
I won't
because-
sleep
yeah.
here, I won't sleep there, but then I come on a Friday night, I'll go to bed early and sleep.
Yes, I
you
do
feel
that.
great
That's
the
me.
next day, but you're not catching up anything.
I feel
There's
useless. the next
deleterious effects to your body by not sleeping. So it's with regards to aging, with regards to wrinkles, with regards to your skin, with regards to hydration, with regards to so many different levels that you're doing so many bad things. And unfortunately, if you're in a high-powered job or you're busy all the time, your sleep is fragmented, is broken.
You
You're
must
doing
have
yourself a
that
disservice.
medically. You must have
medically
that.
it's a nightmare. Excuse the pun.
Yeah. So I mean that's got to have a long-term
It definitely has
impact.
deleterious effects. So it definitely affects your heart. It definitely affects so many different functions in your body that long term you're doing damage to yourself. But what are the choices?
Let's just talk about, when we speak about the amount of sleep that people need, is it possible that people need less sleep than others
Yes.
do?
So
Because I can't sleep more than 6 hours a night.
Well, that's because
Maybe.
you got FOMO. That's a completely different reason.
It is true. It is true. There is so much going on
Yeah,
out there.
100%.
And I want to
that's
be part
different.
of it.
That's different. Okay. But
No, seriously.
certain people can survive on 5 to 6 hours sleep a night. You almost can train your body. It doesn't mean it's good for you. You can survive, but it doesn't mean it's good. Most people need at least 8 hours. Some people need more than 8 hours. Some people
What's
need
interesting,
10 hours.
though-
It just depends on your body makeup and the way you physiologically adapt to these things.
What's interesting is, as a kid, I remember not being able to sleep. I can remember night after night being awake. It was before the internet. So I was reading literally with a torch under the bed, but I couldn't sleep as a kid. And I don't think that's changed.
We would have medicated you if you were like in there.
Oh,
No, you
back
would have
then
been
there was
completely- They would have started with circadian or melatonin. They would have given you all other things.
Yeah,
and
for sure.
You would have been a sleeper. We would have zombied you out.
I can
on
tell you,
time.
if my
Yeah.
parents had their way, they would have put me down.
Yeah.
There's
No,
not
no,
even
to sleep, not put you down.
Oh, is that different?
Yes, very different. Yeah.
I get so confused. All right, yeah. So let's. I get it. But so there are people who need less sleep, but it doesn't mean that it's necessarily good for us.
It's not good for you. Yeah.
Right. I would be skinny if I slept more. Is really what you're saying.
Are you asking me to agree with you,
No,
comment on it, or is
forget
that a
it.
rhetorical question?
I want to move on to talk about sleep apnea because you mentioned it before.
Okay, so
More and
before
more
we get on
peop-
sleep
yeah.
apnea, I think there's a lot of sleep disturbance patterns that we can deal with. And to name a few, it's narcolepsy, and that's when a patient falls asleep during any menial task or during the day. They can be sitting at the table and just fall asleep. There's obstructive sleep apnea, which is breathing disrupted sleep.
Okay.
There's sleep-related bruxism, where you clench and grind your teeth during your sleep.
I'm married to one of those.
Are we talking about putting down again?
I
We've
shouldn't
got
have
to
said
be very
that.
careful.
I
yeah.
shouldn't have
Yeah.
said that on the
There's
podcast.
central sleep apnea and obstructive sleep apnea. So central sleep apnea is when the brain doesn't send proper signals to the muscles that control your breathing. And that happens in people like who've had a stroke, for instance, or someone who's
so that's-
morbidly obese and
right,
has
right.
got diabetes and high blood pressure and all other issues. Whereas obstructive sleep apnea is where you don't breathe. Your body doesn't have an ability to breathe. So your breathing is disrupted during your sleep. And there's two facets to that. There's something called hypopnea and apnea. So hypopnea is when you get reduced breathing, you're not taking enough breaths while you sleep. And apnea is when your breathing completely stops. And in order to understand whether or not you've got sleep apnea, you need to do what we call a sleep study. So before you get to the level of doing a sleep study, normally what happens is your partner will complain that you snore too much.
So is snoring a sign of
Snoring
sleep?
is a sign.
Of what type of sleep apnea?
So it can be both. It can be central or obstructive. But generally, the ones we see more often is the obstructive sleep apnea.
Central, I would imagine, as you said, is stroke.
Stroke,
it would
medical
come from a very
comorbidities.
different.
Yeah. If we're talking about just sort of someone who's got none of those type of comorbidities, someone, let's say, who's overweight, there's more chance of developing sleep apnea. And in order to diagnose it, you have to start with the history. Someone comes and says, I'm feeling tired all the time. I don't function during the day. And why is that? It's because they're getting what we call fragmented sleep. So in other words...
So they think they've slept.
They think they've slept. And when you've got sleep apnea, you actually don't wake up in the night without knowing that you actually stopped breathing. So...
It's quite scary.
It is scary because in order to diagnose it, normally they say you need 5 episodes of apnea per hour together with the feeling the next day that you're sleepy,
and how
you
long?
Have restorative sleep, or you're fatigued, or insomnia, or you have to have at least 15 episodes of apnea per hour without any of those symptoms. So now, you're going to ask you how long those episodes are.
How long do you have to stop breathing for?
Anything from 15 seconds upwards. And the average is about 60 to 80 seconds. Now, if you try and hold your breath now for 80 seconds, you'll pass out. Okay? Unless you're trained...
I think you'd have great sleep.
Yeah. I mean, all of a sudden, 80 seconds is a long time. But you actually have to try it. Put your watch on, time it for 8 seconds, hold your breath, you'll pass out. And what happens when you're sleeping is that you're holding your breath. So this is doing damage to your heart, it's doing damage to your lungs, and it's fragmenting your sleep. And what we find, which is very interesting, is people with sleep apnea go to bed much later. And why do they go to bed much later?
Because they hate sleeping.
Because they eat. And why do they eat at night? They eat at night because it's their body's way of saying, don't go to sleep, have something to eat. Because when you sleep, there's going to be trouble.
Wow.
Interesting.
Fascinating. And what does that do? I mean, does that cause high blood pressure, stroke? Is there a greater risk of some form of an event?
Increased blood pressure, stroke, decreased oxygen, changes in your body's insulin and glucose levels, changes in your mood, heart failure. There's so many consequences. You can fall asleep driving in your car because of exhaustion the next day. It can make seizures worse. It really has severe bad effects, and people don't understand the sequelae consequences of sleep apnea, how dangerous it is. It causes enlargement of your heart, it causes swelling of your heart, it causes strain on your heart.
So do you think that without having, maybe they have done the research on it now, but for years maybe we didn't realize that this was the cause of many types of events like this?
I think for years they have realized it, but they didn't have an effective way to treat it. And that's important because before the 80s, the only treatment for sleep apnea was a tracheostomy. They would make a hole in your trachea and put a pipe inside so you could breathe. You would bypass the area.
It sounds very dramatic. I mean, I'm all for a bit of drama, but that's like over the top.
It was dramatic, and it was necessary because that was the only treatment. And what happens during sleep apnea is there could be a collapse of your muscles in your upper airways. It could be in a child who's got large adenoids, large tonsils. In fact, you find with kids that snore a lot, generally they've got enlarged tonsils, adenoids, and when they have their tonsils and adenoids removed, they stop snoring because it causes an obstruction of the airway. So that compresses their breathing tube, it compresses the airway. And you find in people who are overweight, who've got a large amount of tissue in the upper airways, it blocks their throat and you get a collapse of the airway.
So what are the options in terms of treatment?
So the most important one, without a doubt, is weight loss. Weight loss is the first treatment modality in order to treat this.
Right.
Avoiding alcohol, because alcohol causes relaxation of those muscles, and avoid alcohol at night time. Not completely avoiding it, being moderate intake. There are breathing devices, mandibular assist devices that you put in the mouth to keep the mouth open. They've got a small efficacy. They work, but they don't really work, but they can help. There's something called a hypoglossal nerve stimulator, which is an implant device that stimulates your hypoglossal nerve to stimulate your upper airway, which can't be really that much fun.
No.
Sleep position, and then most importantly something called CPAP. CPAP is continuous positive airway pressure. So it's a machine.
Continuous
positive airway pressure.
Airway pressure.
So it's a machine, and you put a tight-fitting mask on your face, and delivers a positive airway pressure into your mouth. It keeps your airways open through a pressure. Now, it's very different to an oxygen machine, because an oxygen machine just gives oxygen, whereas a CPAP machine...
So an oxygen machine would just release oxygen into your airways.
And the difference between oxygen and air, which comes out from a CPAP machine, is air contains oxygen. Oxygen is pure oxygen. Air contains oxygen, nitrogen, all other components. So it takes the purified air that comes through this machine, and it's not being used for the oxygen inside it. It's being used to push those airways open.
So it keeps it, the pressure of it keeps the airways.
And interesting enough, in people with COPD, chronic obstructive pulmonary disease, who've got sleep apnea, you can actually add an attachment onto the CPAP machine to add oxygen to the machine at the same time.
Must be difficult to get used to, though.
So
what's the success with...
Men and women have difficulty in different ways. I found that my female patients struggle dramatically, and my male patients put it on and their life has changed. It can take some of the female patients up to 3 months. Because
men are not used to being in control. That's why.
Well, they're not used to having it so quiet, because you hear the humming noise. So, look, I mean, it's a bit of a bedroom sort of turn-off. I mean, it's a loud noise. You've got a mask on you, but it's a game changer.
But it's a lifesaver.
It's a game changer, yeah. It changes your life in so many ways. You wake up the next day feeling refreshed. You've got more energy. You're able to lose weight because of it.
Right.
You don't have the heart consequences. There's less chance of you going into atrial fibrillation, which is abnormal heart rhythm. There's less chances of sugar imbalances, less chances of heart failure, and it's a proper.
From what age
machine.
is this a concern?
So, as I say, generally it's more common in men. I say 15% of men, 5% of females, but it can be any age in someone who's markedly or morbidly obese or overweight.
Right.
But we generally test mainly in patients over the age of 40, 45 who come complaining of severe fatigue and restlessness and just aren't sleeping well.
But this is where a partner in the bedroom is actually of vital importance to be
unless the partner sleeps dead and doesn't hear anything.
But it is important to alert the partner to it and to say, listen,
so the partner should watch that.
on.
If your husband snores, if your wife snores, watch them when they sleep and don't sit there and stay up the whole night.
Because it's creepy.
See if they stop breathing. In other words, when I say stop breathing, if they hold their breath without realizing whilst they sleep. So if the person's sleeping and then goes, and for 20, 30, 40 seconds they stop breathing, there's a high chance that...
And you want to do something about it.
Yeah.
Where do they go? Do they go to the GP? Do they go straight to the sleep clinic?
You go to your specialist or your GP or something. But I mean, for someone like a pulmonologist, it's a very easy thing to pick up, because when we do lung functions on a patient, there's a specific pattern you can see on a lung function that alerts you to the fact that there's something developing there with regards to sleep apnea, because there's an obstructive pattern with obstructive sleep apnea. So you see an obstructive lung function pattern that will make you more sort of suspicious of it, together with the history. And then you send them to a sleep clinic. And what the sleep clinic does is they put on an EEG, an EMG, and an EOG. Okay, the EEG is an electroencephalogram. So those are those sort of contacts they put on the head. You see it in all the movies. Okay, an EMG is electromyography, where it looks at the muscle tone in the body.
And then they say you're asleep.
And an EOG is an electrooculography, which it actually measures your eye movements during your sleep.
Wow.
Okay,
so they can see the level of sleep.
Right, and it checks your oxygen saturation levels as well.
Wow.
And that doesn't hinder your sleep when you get the test. Okay, this allows them to understand: do you snore? Do you have restless legs? Do you stop breathing? Do you have hypopnea, apnea? And it can help towards the next test, where you have what we call a CPAP titration. And the CPAP titration is when you've been diagnosed with sleep apnea, you can actually have a mask put on for your next test, and they can work out the pressures you need in order to keep the airways open. And there are two types. There's something called CPAP, and there's something called BiPAP. CPAP is a machine that delivers a positive pressure into your airways, whereas BiPAP delivers a positive pressure and then a lower pressure to get the air out of your system. And that's more common in people with central sleep apnea, but also people with obstructive sleep apnea.
And the results are very positive.
The results are very positive. It's a game changer on so many levels. Every person who's gone onto a sleep apnea machine has said it's a life-changing event.
Amazing.
Yeah.
Okay, and that is us on sleep. But I wanted to chat to you about something else. Is last week a nephew of mine had stomach aches, had stomach pain, And it took a while, not in this country, it took a while for them to realize that he was in fact suffering from an appendicitis attack. And ultimately he had to have the surgery, but it was quite complicated because it was left a little bit late. My question to you is, how do we know? We live in a time where we have stomach aches, maybe from stress, maybe because of something else. We sometimes have a bit of a panic attack that maybe is a real cardiac event. How do we know? How do we determine if what we're experiencing at home, because most of us aren't doctors, is something that we need to worry about, or leave for a little bit and then address?
So it's a good question. I mean, as you said, we live in South Africa and we've got an excellent healthcare system, and we've got an availability of many amenities to actually see if something is wrong. But generally, if you present with, let's say, abdominal pain, you're not going to rush off to the doctor. You'll try to treat it. You'll take a painkiller, you'll take a muscle relaxant or an antispasmodic or something for reflux, and you'll see if that settles down. And within 3 or 4 hours, if you've got this severe intractable pain, something's not right. And the differential is huge. But we taught at medical school, when someone comes in with severe pain in the stomach, you got to look at certain lists. And your first list is appendicitis. Your second is an ectopic pregnancy in a female. Your third is gallbladder issues. And your fourth is bowel obstruction. Those are like the top of your list. But not every stomach pain is something so serious.
Right.
So a lot of time we find
and
in children...
And we rationalize a lot. No, I'm sure
we watched House and we've watched New Amsterdam. We've watched all these things. The House is lupus and New Amsterdam is something else. But in children who get severe abdominal pain, the first point of reference is always appendicitis. But a lot of the time it's something called mesenteric adenitis, which is an inflammatory condition. It could be viral or bacterial at the time. They cause inflammation of the glands there, and it almost pseudo-mimics an appendix attack.
I had my appendix out many years ago.
Many
years ago. Yeah, about 35 years ago, which is many.
Yeah.
And when I went to the doctor, he said that whole mesenteric thing.
Yeah.
Yes.
So that's the thing. So if there's a suspicion that's appendicitis, let's say you go to your doctor, the first thing your doctor's going to do is first he's going to palpate your abdomen. He's going to feel the abdomen and say, hold on, you've got pain over your appendix area.
Is appendix left or right? I never can remember.
On your right-hand side.
Right-hand side. Okay, I mean, I've had them out. I don't know why I'm worrying. Yeah.
Oh, you never know. You might have regrown it.
I actually could have.
You possibly could have,
I probably did.
No one else in the world has, but you have.
Fine. So it's on the right.
It's on the right-hand side. So if they're suspicious, there's normally 2 tests they do. One is a blood test and the other is an ultrasound. The ultrasound will give you sort of some relevance saying, hold on, you might see an inflamed appendix, and then they might send you for a CAT scan and it will show you if there's definitive or not. But if they can't make up their minds, if it's kind of a grey area, then they do blood tests, and they do what we call a white cell count and a CRP. If the white cell count and the C-reactive protein are raised together with changes in the ultrasound or CAT scan, then it's a no-brainer. Once again, then you know it's an appendicitis, and you take that appendix out. Because if you don't take the appendix out, it can perforate and you can cause absolute havoc in that abdomen. You can get a peritonitis, which is inflammation there, and septic shock, and a whole lot of issues can develop there. And it's a very simple operation. It's bread and butter for the surgeons. Okay. It can be other things, as I say, in females. It can be ectopic pregnancy. So you've got to find out, is it a female? Is she of childbearing age? How bad is the thing? When was the last period? You've got to find out all these questions. It can also be a simple thing like a gastritis, which is inflammation in the stomach. And then, are you refluxing? Have you got acid? Are you stressed? Etc., etc. There's so many different differentials, but it's very easy to work out what it is, and very quickly with all the amenities we've got available.
Now talking about things where you don't know difference between, what's the difference between, I know there's a massive difference between a heart attack and a panic attack, but is there a way for a lay person to tell?
So yes, so I remember many years ago, someone I know very well said they had severe chest pain, and they thought it was coming from their stomach. So they took an Nexium, and then they took another Nexium, and a few hours later they took another Nexium, and it still wasn't getting better.
That's a lot of Nexium.
Yeah, because if you do have a gastritis, you would expect something like Nexium, which is a proton pump inhibitor, to work and stabilize that acid. So if you've got chest pain, and if on your left side, and you've got pain going down your arm, or you start sweating, or you've got this crushing pain that you feel like you've got a vice all over your chest, chances are it's something cardiac and you need to take it very seriously. So a panic attack is very different to a heart attack, but you can't exclude the fact that you aren't having a heart attack if you're having a panic attack, because you're still going to get chest pain. You're still going to get pain down your arm.
Okay, so you
can't
get
take every
all of
cough to the
those.
doctor, but this type of thing you do take to the doctor.
Right.
And it's very simple to work out. You do an ECG, you do blood tests.
What blood tests do they do? They
So
always do
something
their
called
blood test.
troponin T,
Yeah.
cardiac enzymes, and what you call a CKMB. Okay, and these type of tests will tell you if these elevated enzymes of the heart are raised or if they're elevated, and will give you an idea that there's something going wrong. And once again, if they're suspicious, they do the heart enzymes, and a few hours later they repeat them. And if they're going up together with what looks like a positive ECG change, they'll take you to the cath lab and do what we call an angiogram.
And that's how you'll know.
That's how you'll know.
Very, very interesting indeed. That's all we have time for, unfortunately, today. Don't forget to subscribe and let us know in the comments what else you would like us to talk about. I'm Howard Feldman. This has been an episode of Is This Going to Kill Me? With me and Dr. Anton Meyberg. Have a fantastic week. God bless.
Is This Going to Kill Me? A health podcast with Howard Feldman and Dr. Anton Meyberg.